Looks like we have a USP cluster here. Uh, but now I'm working at Indiana University in Bloomington as a postdoc. So a little bit about our lab. I am supervised by Professor Marco Aielli. He's going to be here on Thursday. I think he's taking a plane now. And we are basically an applied epidemiology, a computational epidemiology lab. Let me see, that's the laser. OK. So we have a couple of ongoing projects. Most of them are really applied. We want to give actionable answers to public health questions. So we're working with multiple vector-borne disease projects, mostly mosquito-borne diseases. So we do have some projects with dengue, but we are also focusing on modeling mosquito population dynamics. And we have also forecast of hospitalizations by flu, COVID, and RSV. So I am basically carrying the flag on that. We also have a more recent work with RSV and the newly rolled out vaccine. But today I'm going to talk with about what I consider our more basic science work, which is agent-based models in a data-driven setup. Okay, so introducing the subject. Many of you might have heard about epidemic models, and I'm going to emphasize two types of those models. The first one is between host models, and it's probably what most of you are familiar with. Is when you simulate the spread of a pathogen between hosts. So if your host is human, it's from person to another person, and so on. But there are also within host epidemic models in which you simulate the spread of a pathogen inside the organism of a host. Okay, and well, also, as an introduction, I will mention some epidemiological quantities which can be estimated with those models. And we have a couple of quantities that are important to epidemiologists, but I'm going to emphasize these two here, the generation time and the pre-symptomatic transmission. Generation time is basically the time between two consecutive primary and secondary infections. So if you take patient A here, infected on day 0, and this patient infects another one on day 5, so the generation time is 5 days. And then patient B to C will take 3 days, so that's the generation time of those infection events. And this is a very important quantity because it's basically the inner clock of an epidemic. So epidemiologists are very interested in knowing this number as soon as possible when you have an outbreak. Also, another important quantity is the pre-symptomatic transmission rate. So if you look at the transmission here from B to C, you have that infection occurs before symptom onset of the infector. So it's important to know how often this happens because you're going to infect people before you even realize you're sick. So that's important for designing policies for intervention and isolation. Okay, so those are two important quantities. And the thing is that you can use, for example, within host models to estimate those epidemiological quantities, because the within host model will give you the pathogen load, or if I can say from now on, the viral load over time, which can be a proxy for the infectiousness over time. So how infectious is that host? And with that, you can calculate generation time and pre-symptomatic infection rates. However, to do that with a within host model, you have to make an assumption that basically have infinite susceptible contacts. So that's a strong assumption. It's basically you cannot have the propagation dynamics. But in reality, human contacts are more like that. They're clustered. They happen in small size clusters. So you have a limited pool of people to infect, and you can also have some competition effects. So our question is, what are the biases that can be introduced for having this assumption in a within host model? Okay, so how big is this bias in a realistic setup? So our goals, as stated, is to build a multi-scale model. And multi-scale means that we're going to combine the within host and a between host model. In a data-driven setup, using SARS-CoV-2 as a case study. And we choose SARS-CoV-2 because we have a lot of data about this pathogen. So, we want to calculate epidemiological quantities using this multi-scale model and therefore estimate the biases that we get from within host models in this data-driven setup. Okay? So let me explain very briefly this multi-scale model that we built. So first, the within-host component starts with some data from SARS-CoV-2 infected patients, both symptomatic and asymptomatic. So this was mostly done by our collaborators here, and they use this data to calibrate a within-host model, which is an ODE model of 3 dimensions. And so this is calibrated with real data, and you can reproduce what you would expect in reality, as better as the data, as good as the data is. Okay, and then how do I use this within host in a between host model? It's simple. You take the viral load dynamics and you put a threshold. Under this threshold, you are latent. So you start here, if you get infected, you start susceptible. Then you go to the latent period, you're not infecting anyone, but you have the pathogen. Then you go over the threshold, you start infecting people, and proportional to your viral load. And after you go over the threshold, below threshold again, you are removed. So you're no longer infectious, and you're basically immune in this simple assumption. Okay, so that's how our between host model happens. And most importantly, for the context of this event, is the network behind this. So the network is a 4-layer multiplex network using census and survey data. This was made in a 2021 published paper. And basically, you use features from the data that you have to construct the distributions of household sizes, workplace sizes, and so you construct those layers. Each layer is made of fully connected clusters. So it's hard to see here, but imagine one household will be a full graph of n people. And those graphs are disconnected in this layer, but they can be the people can be connected in other layers, like workplaces and schools. And the community special one is everything else. Since we don't have exact knowledge on how it works, it's just an all-to-all fully connected graph. So that's our network. Okay, and so we're combining a within host layer with a between hosts. And this is our viral load individual-based epidemic simulation, ladies and gentlemen, our VIBES model. And apparently the CDC likes models with names, so we had to find a name. So to the results, I'm going to also be very brief here. But basically, what I'm proposing here is to estimate those biases. So here they are. The trace line is what you get if you use a within-host model only for the generation time. And the solid points are what we simulate with our VIBES model. And as you see, there might be a significant bias. It's not a crazy number, but it's significant. So here's for 2.5 in the reproduction number, you get 8% of a bias. But as you increase the infectiousness, you have an effect that the generation time decreases, so your bias is bigger. It can be up to 17% for a reproduction number that the basic reproduction number is compatible to the Omicron variant, for example. And same thing here for the presymptomatic transmission rate. You can have significant biases. It increases as your reproduction number goes up, okay? So basically, if I still have some time, I think so, why this decrease happens, it's because in a realistic setup where you have limited contacts, you can have a competition effect. How is this competition? Well, imagine a household of 3 people. If you have 2 infectious people, then the first one to infect the other one takes the score. The first one to infect will register the generation time. So, as to say, the generation time is going to be the minimum between the 2 theoretical generation times for each of those people. So it's always the minimum between 2 quantities. So when you have clustered contacts, your generation time tends to be shorter. And same thing happens is if you increase the reproduction number. You start infecting people sooner rather than later. So your generation time goes down. And this cannot be captured with the within-host model only, but can be captured with our multi-scale model. Okay? As a bonus panel of results, we can also estimate the generation time by symptom onset. So this is for asymptomatic people, and that's for symptomatic people. This is asymptomatic and symptomatic. And as you can see, there is a difference. And What is the big thing here is that because asymptomatic generation time is very hard to obtain from the field, simply because asymptomatic people is hard to detect. You have to be testing people every week or so, and actually every day or so, because you want to measure the generation time. So it's difficult, but our model can provide us estimate as long as you have data for that pathogen, and we did have for SARS-CoV-2. So with that, I have the conclusions. So for the study that I presented here, we conclude that there might be significant biases from using a within-host model for estimating those quantities. People do it, the estimates are good, but there is some bias to consider, and we are showing exactly these numbers for using our multi-scale model, okay? And also, importantly, this bias increases as the virus becomes more infectious, which also was the case for SARS-CoV-2. And I also showed that we can use VIBES model to estimate quantities that are hard to obtain from field studies. I showed the asymptomatic generation time as an example. And not shown here, but we also had some other things that we did with VIBES. So for example, you can use it to test individual targeted interventions. So for example, testing, contact tracing, and isolation policies. This is very, there's a lot of demand for modeling this kind of interventions from the CDC and from public health authorities, because you want to know how effective they are, and you can actually use the within and between host models to know this with a better estimate. Also testing antiviral drugs, because they act on the viral load. So you simulate the viral load, and then you simulate what is the impact for the entire outbreak. So a multi-scale model is also adequate for this kind of estimations. And there are many other things that I would definitely not have time to talk here. So let me do the acknowledgements. This is the team behind this work. The three of us here in the CPH lab, but we have a much bigger team there. We have our external collaborators working especially on the within-host part. And, well, we're funded by the CDC and CSTE. So, again, we're Apply Lab. We want to do actionable answers to questions of public health concern. And you can reach me out here. Please send me an email if you want to know more. Find me on my website. And especially, I will still be here on the conference. So come and talk to me. I'm very open to discussing this. We might be looking for a postdoc position soon. So stay tuned. Talk to me about that. And that's it. This is for my Google Scholar. Thank you very much.
Hey, thank you, Paulo. We have time for questions.
Hi, thank you for the talk. I don't know if you come back to the slide with the multi-layer graph.
Okay.
Yeah, that one. I didn't understand well what are the connections between the layers.
Okay. Yeah, so this is particularly not just a multi-layer, but a multiplex. So the number of nodes in each layer is the same. And by that, we mean that each node here will have a corresponding node here that is the same person. So
yes.
You see what I mean?
Yes.
So the connections here represent the same person. So this connection here represents I am this guy, I am this guy, I am this guy.
Perfect.
Basically. Does that answer? And
yes, yes.
Okay.
Okay, hi. I wanted to ask, you said that the model was calibrated with real data from real patients, the within-host part of the model.
Yes.
So I imagine if you wanted to do a different virus, you would just get data from that virus and apply it to the same model.
Mm-hmm.
But if you wanted to do, for example, a bacterial disease or maybe something like that has a parasite or anything like that,
Mm-hmm.
would you be able to just use the same model and use some different parameters, or would you have to model it differently?
Yeah, well, the answer from a physicist is yes, as long as you can measure the pathogen load, which I want to be more generic, so any pathogen works, yes. I don't know if there's any biological limitation for measuring the load of bacteria. I'll leave this to a biologist, but yes, you could in principle.
More questions? No? Okay, so let's thank Paulo again.
Thank you.